All right. I want to introduce, I know we've already introduced Wendy Fowler. She is my East Carolina University grad student, and she is going to do some of the postpartum complications.
Thank you, Ms. Caldwell. Before we get started, does everybody have a copy of the PowerPoint?
Thank you for that.
You're welcome. The case study, evaluation book. Everybody has all 3 days. Great. Again, my name is Wendy Fowler. I am an East Carolina University grad student for the nursing education, go Pirates. And a little bit about my background, because I've worked with a few of you guys in clinical, but not all. I've been a nurse for 15 years. I work at Catawba Valley Medical Center. I have background in orthopedic nursing, inpatient rehab, case management, discharge planning, and I'm talking to you guys today about postpartum care. I don't have postpartum in my background, but like what Ms. Caldwell and Ms. Kiesler say, your med-surg background, your basics will follow you throughout all of your patient population, from your pediatrics to your geriatrics. So I know a lot about my med-surg, and we're going to tie those together and tailor those med-surg topics today into postpartum complications. So first off, our objectives today, your learner, which is you guys, are going to be able to recognize the signs and symptoms of postpartum complications to your patient. You guys are going to be able to implement interventions related to the treatment of postpartum patients and to the complications that they encounter. And you're also going to be able to discuss patient education. Patient education is a big deal whenever you have patients with complications. So we're going to learn some patient education topics and be able to take care of those patients. So our first topic today is thrombosis. Like what Ms. Caldwell says, what is it? What is a thrombosis? It's a blood clot within the vascular system. It's also known as venous thromboembolism, VTE. VTE occurs in 900,000 people annually. That's a big number. And over 1/3 of these VTE cases can lead to death. So this is a very serious thing for having these thrombosis, these blood clots. This is broken down into 3 different sections. SVT, which does not stand in this case for supraventricular tachycardia for your cardiac patients. This is more for the thrombosis. This is superficial venous thrombosis. It's in the saphenous veins or the superficial veins. Also DVT, deep vein thrombosis, more in the deep veins. And that could be anywhere throughout the body in the deep veins, but mostly we focus on the ones in the bilateral lower extremities. Also thrombophlebitis, which is a clot that's formed in response to inflammation in the vein wall. How can you get a thrombophlebitis? Can somebody tell me how a thrombophlebitis can occur? Anybody have any ideas? Infiltration of the IV site. The inflammation from the infiltration of that IV site can lead to thrombophlebitis and then can lead to a blood clot. So what causes thrombosis? Particularly in the postpartum patient, it's the increasing clotting factors of fibrinogen during pregnancy and during the first 6 weeks after delivery. Also, there's other risk factors that include C-section births, endometritis, immobility, multiparity, trauma to any extremities, varicose veins, advanced maternal age. Anybody over 35 years of age is at risk for that. History of coagulation disorders. If they've been on hormone use, they've had replacement or oral contraceptives, and then also diabetes is a big risk factor as well. So what are you going to see as a nurse? Your signs and symptoms for an SVT, you're going to see localized redness, tenderness over that superficial vein. For a DVT, you traditionally will see utilized leg pain, so just in one leg traditionally, that extends up above the knee, mainly in the calf areas where you'll see that tenderness and swelling. You can also see a positive Holman sign. Does anybody know what a Holman sign is? Can someone tell me what Holman sign is? When you dorsiflex and they feel that pain in that calf area, that's a positive Holman sign. Also, low-grade fever and chills could be a sign as well. diagnostic test, what are you gonna see? What confirms a DVT? That venous ultrasound, exactly. So we'll get the physician to order that to confirm that there is actually a blood clot there at DVT. So that goes into your nursing interventions here. What are you gonna do about it? This is an emergency. You do need to call the physician immediately. You need to assess for edema, assess the peripheral pulses, temperature, color, and tenderness every 8 hours or more often if the patient is complaining of signs and symptoms. Assess the Holman sign. Maintain bed rest during the acute phase. Why would we want to keep somebody at bed rest if we think they might have a blood clot? Absolutely. And how does that happen? Absolutely. When they get up, those muscles in the legs, they contract around those veins, and it brings that blood clot up to the heart, brain, or any place else like that. Absolutely. For comfort measures, you want to provide warm and moist compresses and elevate that affected limb as well. So what are we going to do about it? Treatment, medical-wise or medication-wise in the hospital, they're traditionally put on heparin IV drip. It's an anticoagulant, unfractionated heparin. It is dosed by weight-based nomogram. Labs, they check PTTs every 4 to 6 hours. And for that level of the PTT, that's when they'll adjust the dosage of the heparin IV drip. This is also started in the hospital to help bridge long-term Coumadin or warfarin at home. And the therapeutic level that they want to get the INR level up to is above 2.0. Also, another treatment for that they're doing more often too is sub-Q Levinox, enoxaparin. This is something that they'll give in instead of giving a heparin IV drip, because the patient can go home on Levinox. It is an anticoagulant. It is the low molecular weight heparin. And the dosage is 1 milligram per kilogram every 12 hours for a 7-day treatment therapy session. And traditionally with Levinox, there is no labs needed. I'm going to bring into this a little bit of case management. Does anybody know what the cost of Levinox, the actual brand, would cost for a patient that pays self-pay?
It's like $600-$700 or something like that.
Yeah, it is expensive. Actually, what it is for a self-pay patient, it is $1 per milligram for Levinox. So somebody like me, I weigh 180 pounds. If I was to take a 7-day course of this, it would cost me out of pocket over $1,100. And I don't know about you guys, but I can't just drop $1,100 at one time for a prescription. So just be kind of mindful of that, because we do get self-pay patients into not just postpartum area, but also just through the general med-surg area. We get a lot of self-pay patients, and they don't have coverage, so it's going to be very expensive. Also, our Medicare patients, if they don't have a drug plan, there's no coverage for them, so they'll be paying out of pocket as well. So if you have somebody that's having financial issues or can't afford their medications, who's somebody that you can reach out to in the hospital that can help? Good. Case management, social worker, and they can do things like that. Awesome. Okay. So for thrombosis, the long-term treatment, like I said, is warfarin or Coumadin together, and it is an anticoagulant. It's a vitamin K antagonist, and they usually dose it daily. And again, the dosage depends on the INR level as well. In the hospital, the therapeutic INR is 2.0. In the hospital, they'll draw daily INRs to make sure that they get that therapeutic INR. And once they go home, if they do have an acute DVT, they'll more than likely have the patient come back into the physician office within 2 to 3 weeks to get the lab drawn as well. But after that, it'll be monthly. And then you also want to monitor and educate your patient about avoiding vitamin K foods. So we're bringing pharmacology into this. Why is vitamin K so important when the patient takes Coumadin? Absolutely, yeah. And what are some vitamin K foods that you would tell your patient to avoid? Spinach.
Avocado.
It's not like green leafy vegetables, so like the spinach, kale, mustard greens, collard greens, things like that is the main thing. But there is some in avocado, but it's those main green leafy vegetables that you want to tell your patient to avoid. Also, patients that are on anticoagulants, we want to monitor for signs and symptoms of bleeding, and those include unusual bruising, bruises that develop with unknown cause and they grow in size, any nosebleeds, bleeding of the gums, coughing up blood, pink urine, because that shows that there's blood in the urine, red or black stools, or vomiting blood that looks like coffee grounds, so coffee ground emesis. All those are signs and symptoms of bleed. And you as a nurse want to watch for these while they're in the hospital. And along with that, you want to teach your patient these signs and symptoms when they go home as well. So for patient education, teach those signs and symptoms of bleeding. Stress the importance of medication adherence and lab work adherence. Lab work for warfarin. Why do we want to stress the importance of making sure that they take their Coumadin daily and that they follow up with their labs? Because with Coumadin, because they have a blood clot already, and if they're not taking their medications, they're, set up to get more blood clots. So you really want to just, emphasize the importance. Take your medications daily and make sure you do your follow-up appointments and get your follow-up labs completed. Also, reporting worsening signs and symptoms to your healthcare provider. And then also, call 911 for any difficulty breathing. Why would we want to stress calling 911 for any difficulty breathing for your patient? Okay, a DVT could have possibly moved up to the lungs, absolutely. And then for prevention techniques, to prevent thrombosis, you want to encourage your patient to wear their compression stockings, wear those TED hoses, SCDs, encourage getting up early and frequent ambulation to get that blood moving. And then also foot pump exercises. Does anybody happen to know what a foot pump exercise is? I see you doing it, Dana. What is it?
Pressing on the pedal and,
That's it, pressing on the pedal and letting up on the gas with your feet, because what it does is it gets those muscles and those calves contracted to get that blood back up to the heart. Absolutely. Okay, so our first question here regarding thrombosis, you have a postpartum patient that is at high risk for delivering thrombosis up until how many weeks after delivery? Is that A, 2 weeks, B, 4 weeks, C, 6 weeks, or D, 8 weeks? Absolutely, 6 weeks up to delivery. Absolutely, good job. Okay, well, we're going to move on to our next topic, which is pulmonary embolism. So we started with the DVT, and now we've moved up to the lungs. So now we have a PE. So what is a PE? It occurs when the pulmonary artery or the branch is obstructed by a blood clot because it's broken off and it's launched into the lungs. What causes the pulmonary embolism? Same thing as thrombosis. All of those causes for pulmonary embolism are what call that. All those that causes thrombosis is going to cause pulmonary embolism. And over 95% of those pulmonary embolisms do start as a DVT. So that's why it's so important to try to prevent DVTs so it doesn't get worse and become PE. So what are you going to see with a pulmonary embolism? Signs and symptoms of a PE include dyspnea, tachypnea, coughing up blood, hypoxia, tachycardia, hypertension, chest pain. Sometimes you'll hear a heart murmur on the right side of the heart. You'll also have peripheral edema as well. Distended neck veins, JVD. Does anybody know what JVD stands for? Jugular vein distension, exactly. You'll see the jugular veins distend, and you'll see it sometimes pulsating. You can also see an elevated temperature, chills, diaphoresis or sweating, and having just anxiousness and apprehension, just a sense of impending doom. Can someone tell me what a sense of impending doom is? And know something bad's going to happen. They don't know what's happening with them, but they just feel like they're going to die. They just don't know what's happening, but I just feel like I'm going to die. You can hear a lot of patients saying that. So what are you going to see diagnostic-wise? You're going to confirm it sometimes on a chest x-ray, but more likely on a lung scan, VQ scan, or a CAT scan of the chest is what you'll see it. Sometimes you'll have an elevated D-dimer. ABG, you'll have hypoxemia and respiratory alkalosis. So nursing assessment, what are you going to do about it as a nurse? You're going to check the respiratory status, check vital signs and temperature, listen to heart sounds, assess that JVD, the neck vein distension. You're going to assess mental status and pain level. So what are you going to do about it? This is an emergency. Notify your physician immediately. Place your patient in a semi-Fowler position, have the head of bed up, elevated, administer oxygen, administer pain medications as the physician orders. And then the same thing with the anticoagulant treatment, either the heparin IV drip, the noxaparin, Levinox, or Coumadin. So that's going to be the same as thrombosis as well. Long-term treatment is going to be long-term with Coumadin, same as thrombosis. The only thing different with the PE is they're going to continue Coumadin for a little bit longer amount of time. So for a PE, they're going to traditionally keep the person on Coumadin for 3 months versus 6 weeks for a DET. And so patient education, again, same thing as thrombosis. Educate your patient about those signs and symptoms of bleeding when they're on the anticoagulant. Stress that importance of medication adherence and lab work with Coumadin at discharge. Stress the adherence to a low vitamin K diet. Again, reporting those signs and symptoms of worsening symptoms to the physician, and then also calling 911 for any difficulty breathing. And again, same thing for prevention, wear the compression stockings, encourage ambulation, and those foot pump exercises as well. So our question with PE, what is a sign or symptom that could indicate that the postpartum patient may be having a pulmonary embolism? Is it A, bradycardia, B, chest pain, D, decreased temperature, or D, hypertension? Chest pain, awesome, that's right, good. And why would the other three not coincide with pulmonary embolism? It's the opposite, good. Okay. So, our next topic is wound infections. And for the postpartum patient, you'll see this in C-sections or perineal infections. So what is a wound infection? It is an open site in the skin that allows bacteria in and creates an infection. Simple as that. So what causes a wound infection? For the postpartum patient, the C-section wound, the episiotomy wound, or the perineal tear wound. Also poor hand hygiene, not properly washing your hands, and then also compromised health status. Patients been on steroid therapy, if they're obese, or if they have diabetes. So what are you going to see with a wound infection? For the C-section, you're going to have abdominal pain and distension. The episiotomy and perineal tears, you're going to see some severe pain in the perineal area. You can also see foul smell and lochia, or tachycardia. Tachycardia is usually more on the last end, but that's also there that you can see. So what other things you're going to see? In your nursing assessment, RETA. So we're bringing in the RETA again. So for the wound infection, R, you're going to see redness. E, you're going to see edema. The other E, you're going to see ecchymosis. D, you're going to have drainage. It's going to be purulent drainage with pus. And A, you're going to see approximation. Sometimes that wound is going to dehisce. It's going to come apart. Diagnostic-wise, you're going to see an increase of the white blood cell count greater than 30%, but that's only going to happen after about a 6-hour period. So that's going to take a little bit of time before you see this issue. You're going to see more of the skin, the RETA, before you'll see the white blood cell count elevate. So what are you going to do about it as a nurse? You're going to assess the site, perform RETA every 8 hours, obtain a wound culture. And why would we want to obtain a wound culture? Get the right antibiotic for what reason? Staph infection. There you go, to see the specific bacteria, to make sure that we have them on the right antibiotic treatment. Good job. You're going to check vital signs, administer the antibiotic for what the physician writes, and for the healthcare provider, use aseptic technique. Make sure you're washing your hands, make sure you don't drop the dressing on the floor and pick it up and turn it back on. You've seen some people do that before, and that is not good, because you're just picking up that bacteria. All right. And then the same thing for patient education. You're going to teach measures, to prevent further infection. So what are some measures you want to teach the patient when they go home to prevent infection? Hand washing is key, absolutely. What's some other things? When they have an open wound, keep it covered, absolutely. What's that, I'm sorry?
Dressing changes.
Doing dressing changes, absolutely. And whenever you do dressing changes, though, how would you tell them to do the dressing change?
Take off the old space properly.
like the aseptic technique, keep it clean. Because with that, and sometimes you have to stress what clean means, because I've had patients that have come in with wound infections, and just talking back to them, they have let their little kids play with the dressing while it's been open, or they've let their dogs or cats lay around on the sterile dressing. And sometimes I've had somebody comment to me, well, my dog's mouth was cleaner than mine, so I thought it was fine for them to pick up my dressing. So again, this is re-educating your patients and, making sure that they are at the right level of education and really know what clean means or sterile means. So, some other things for infection prevention that you might not think of is tell them to avoid submerging themselves in a tub. No tub baths, no getting in pools, no getting in spas, saunas, hot tubs, because those are all cesspools of bacteria. When you have an open wound, you can easily get in there. So just tell them to avoid all that. They can do like sitz baths for perineal, like the little perineal bottles to wash with. They can use that. Tell them to have adequate fluid intake, increase their fluid intake, encourage diets in high protein and vitamin C. Why would we want to encourage diets with high protein and vitamin C? Exactly, it promotes those healing processes, absolutely. And then also doing comfort needs, so warm compress and analgesics as well will help. So question for our wound infection, for the postpartum patient going home post-C-section, what is the most important element of patient education to emphasize to them to prevent wound infection?
Hand washing.
There you go, D, hand washing, didn't even have to go to the rest, awesome. And that is the main thing, and that's the thing too with healthcare providers, you tell your patients to perform good hand hygiene, but healthcare providers, you've got to have good hand hygiene as well, So the next topic is urinary retention. So what is urinary retention? It's defined as an absence of spontaneous urination within 6 hours after a vaginal delivery and within 6 hours after removal of a catheter after a C-section. So that 6-hour mark is the main thing. What causes urinary retention? Bladder hypotonia, which means where the bladder is flaccid, it's not contracting. Urinary stasis. Catheterization will do that as well. Epidural anesthesia, a lot of our mothers are getting that epidural anesthesia. That also, decreases the contractions with the bladder, so it's going to increase urinary retention. C-section and bacteria in urine, bacteria. So what are you going to see? Some signs and symptoms in the postpartum patient. You're going to see an overdistended bladder, which will appear as a large mass. It'll displace that fundus upward. And you're going to have a patient that's restless, they're having backaches, abdominal cramping. A diagnostic to see for sure how much urinary retention is performing a bladder scan. So what are you going to do for urinary retention? Assess that firmness of the uterus. You're going to encourage early voiding, so getting them up and moving to help, promote them urinating. You can give them ice packs. Pain medicine can help. Also, you can do peri-care, sitz baths, peppermint oil. Peppermint oil is new to me, because again, I haven't been postpartum, but what can peppermint oil do for postpartum patients that's having urinary retention? It does. What it is, and can somebody tell me what you do, Lord? How would you administer the peppermint oil to the patient? Okay. That's right. You put it in a little hat with a little bit of water, and what it'll do is those vapors will come up, and what it does is it stimulates the urethra to help release that urine. So, good job. And then you can perform a bladder scan if the patient is still unable to void. And each facility has a little bit of different protocol. I looked at CDMC. Their protocol starts when there's retention of at least 400 cc's off the bladder scan, and that first step is to do an in and out catheter. And then they have a huge list of how you go through, this and that. So every facility is different, so just become familiar with your particular facility's protocol. And so if you have a patient that has a large amount of urine in and you are catheterizing them, you want to clamp after getting 900 to 1,000 cc's out. Why would you want to clamp it after that amount? Okay, why do you want to do it slow? There you go, stop bladder spasms. Good job. All right, so with patient education for urinary retention, you're gonna encourage early voiding, getting them up, getting them moving. Give ice packs, pain medication, peri-care, sitz baths, that peppermint oil. And if you have a patient that still continues with urinary retention, if you can't get the catheter out in the hospital, sometimes they send them home with the catheter. So you've got to do patient education as well for catheter care. Give them a leg bag, again, teaching them proper aseptic technique when cleaning to help prevent any type of urinary tract infection from that catheter. Excuse me. So question on urinary retention. The postpartum patient is experiencing urinary retention after a C-section delivery. What could be a possible cause? That's right, good job. Anesthesia, because she had that C-section, and that anesthesia is what helps put the bladder to sleep. Okay, and our last topic is on urinary tract infections. So what is a urinary tract infection? And it's broken down into two different topics. Cystitis. Cystitis is a urinary infection that is from the urethra to the bladder. And then also pyelonephritis, which is mainly the infection of the kidneys, which is the upper urinary tract from the bladder up into the kidneys. So what causes urinary tract infections? Retention of that residual urine. So that's why it's so important to overcome urinary retention so it doesn't lead to UTI. Bladder trauma from having catheters put in. Catheter contamination. Again, this goes back to the healthcare professional too, of not maintaining sterile technique when placing in a catheter, or not properly cleaning the catheter and ending up having infection. Poor hand hygiene, not wiping from front to back. So that's the main thing, you need to teach patients, wipe front to back. Because E. coli is a major cause. And where does the E. coli usually come from? From the back end, yes. So what are some signs and symptoms that you're going to see of a urinary tract infection? You're going to have urinary frequency, urgency, nocturia, burning of urination, suprapubic pain mainly for UTIs, blank pain for pulmonary, excuse me, pyelonephritis, fever, chills, nausea, and vomiting. Signs and symptoms in the postpartum patient usually appear within 2 to 3 days after delivery. Diagnostic-wise, you could have a positive urinalysis. You'll have increased white blood cell count, positive bacteria, nitrate, leukocyte estrase, and then positive urine culture. You might not immediately get a positive urine culture, but it's good to take that because, again, with the fluid infection, we want to make sure we know which organism is causing this UTI so we can have the proper antibiotic treatment. And again, for the nurses, what are you going to do about it? You're going to administer the antibiotic as the physician prescribes. Acidify the urine in the cranberry juice. So I know you guys are in microbiology right now. Is that correct? No? Have y'all had microbiology? Okay. We're going to bring that microbiology in. So why do we want to increase the acid level in a patient's urine that has UTI? Exactly. The bacteria does not like to live in acid environments. So if you increase that acid level by giving cranberry juice or something like that, that'll help to kill off the bacteria, or they won't proliferate. They won't grow in that environment. Same thing with offering juices low in sugar. Bacteria loves sugar. If they don't have sugar, they're not going to grow off of it that well. And then also avoid carbonated drinks. So for patient education, again, teaching the importance of wiping back, front to back, encourage fluid intake, preferably water, encourage cranberry juice, and stress the importance of completing their antibiotic treatment. Why do you want to stress the importance that the patient completes their antibiotics? Resistance. That's the main thing, yeah, resistance. And also, so it doesn't come back. Absolutely. Okay, so our last question. Symptoms of UTI in the postpartum patient usually occurs within what time frame post-delivery? Say that again? 2 to 3 days. 2 to 3 days. Awesome. Good job. All right. And that's the end. Does anybody have any questions? All right. Good. All right. If everybody complication developing case study. We're going to go through that. All right. Okay, so we're going to get started with the case study. I'm going to start off with Jane is a 40-year-old female. She is gravid of 3, a parent of 2. She is at 41 weeks gestation. She admitted to the hospital for induction of labor. This baby is not coming out. Her weight, she's 260 pounds, and she is 5'2". Jane has a history of diabetes, and her current blood glucose reading is 185 2 hours postprandial. She is prepped with her hospital gown. She has her IV site started, and they have begun a Pitocin IV drip. The nurse encourages Jane to get up and ambulate to help facilitate labor. She refuses. After about 12 hours on the PIT IV drip, Jane is only dilated 2 centimeters, and she is only at -3 station. Jane's tired. She's been laboring for 12 hours. Nothing's going on, so she requests that the Pitocin drip be turned off for the night so she can rest to start induction again the next day. So in the next morning, Jane's nurse restarts the Pitocin IV drip, and again she encourages her to get up and ambulate again to progress labor. Again, she refuses. After another 12 hours of induction, Jane's only dilated at 4 centimeters, and she's at -2 station. The fetus then begins experiencing fetal distress, and the fetal heart rate decreases to dangerous levels. Jane has a Foley catheter placed. She receives an epidural, and she is rushed to the OR to undergo an emergent C-section. Jane has a beautiful bouncing baby boy. 6 hours after Jane has her Foley catheter removed, she is unable to void. What is this condition called? Good, urinary retention. So what are some possible causes of this urinary retention that Jane has experienced? There you go, prolonged catheter use, anesthesia, and what did she just undergo? C-section, yes, absolutely. So what are some interventions that can be used to help Jane overcome her urinary retention?
Peppermint oil.
Peppermint oil, good job. What are some other things? Absolutely, getting up, encourage ambulation. It's a possibility, but there's some other options too that we could use. What are some other things? There you go.
Increased fluids.
Increased fluids can help some too. What are some interventions that the nurse can do to help her overcome this urinary retention? Run water, sits bath, absolutely. We do more peri-care. Sit ice packs, that's right. And what if she's still unable to void? You can do a bladder scan, in and out, but that's at last resort, correct? The least invasive is what you want to start with at first. Okay, so Jane, bless her heart, she is unable to void, and she has her catheter replaced for a second time. Jane's nurse encourages her to get up and ambulate, but now with her having a Foley catheter in place, Jane states, I have no need to get up. The baby is out. I've got this tube to pee in. So what would be your response as a nurse to Jane when she says this? Uh-huh. And then also, she's at increased risk for what else? UTI. And DVT, good, because she has refused to get up all this time. So with this, Jane's been refusing to get up and ambulate all the time. So as a nurse, there's some things that you can work around. Whenever you go in to ask a patient, watch how you word your questions. So instead of going in to ask Jane, do you want to get up? What is Jane's options? Either yes or no. That's it. So instead of phrasing it that way, think about phrasing it as, come in and say, Jane, when would you like to get up? When would you like to get up? It gives her options. Before breakfast, after breakfast, before I feed the baby, after I feed the baby, before I watch the Kardashians, after I watch the Kardashians. So it gives you a multiple array of times instead of just yes or no. And so that gives her the last option of never, because who's going to say, I never want to get up and walk again? So it's just on how you kind of phrase things. So instead of saying, do you want to get up, say something like, when would you like to get up? So that's just a little thing just to remember. Okay. So after much encouragement with Jane, she does finally get up and she ambulates in the hallway. When she returns to her room, she calls the nurse complaining of pain in her right calf area. When the nurse comes in and assesses her, Jane's nurse notices that the calf is red and swollen. What could be going on with Jane? There you go, DVT. So what are Jane's risk factors that could have led to this condition of a DVT? Decreased ambulation, exactly, and mobility, advanced maternal age, because she is 40 years old, so anybody over 35. Obesity, absolutely. Diabetes, perfect, yes. And then, what did she undergo? That's a C-section. That's right, that's right. And what is the diagnostic test that's going to confirm a DVT? Doppler ultrasound, good job. Okay, so the diagnostic test, the Doppler ultrasound, does confirm that Jane has a DVT in her right leg. The physician orders for a heparin IV drip for weight-based nomogram and strict bed rest. As Jane's nurse, what are some things that you want to consider or be aware of when she is on a heparin IV drip? What are some things? Labs, absolutely. So what are the labs for a heparin IV drip? PTT. Now, what's INR for? Yes, but so particularly for the heparin IV drip, it's PTT. And how often do they traditionally draw a PTT on a heparin IV drip? Every when? Back in your, go back into your power plug. It's in there. Every 4 to 6 hours. There you go. And then what are some other things as Jane's nurse that you want to watch for whenever she's on this heparin IV drip? Signs and symptoms of bleeding. And what are those? What are some signs and symptoms of bleeding? Bleeding the gums, good. Blood in the urine. Check the incision for any bleeding. Red stools. Okay, good. Okay, so the next day during morning rounds, the nurse notices Jane's dressing over the C-section site is saturated. When the nurse removes the dressing, she uses the acronym RITA to assess the wound. So, if Jane's wound is infected, using RITA, what would the nurse expect to observe? So for the first, the R, what would you use? Redness. For the first E, edema. The second E, good. D, drainage. So what type of drainage would you see? Gurgling. Absolutely. And then A, approximation. What would you possibly see for approximation? Dehiscing. Absolutely. Good. So what are Jane's risk factors that have set her up for a wound infection? Oh, yeah, go ahead.
What did you say was approximation? What was that word you said?
Dehiscing, yeah. Dehiscing means that the wound has come apart.
Okay.
Yeah, has opened back up. Good. Okay, so what are some risk factors that have set Jane up for this wound infection? She's had a C-section, so she has the wound, and diabetes, and obesity, absolutely, good job. And what are some important things that the nurse can do when performing wound care for Jane? Hand hygiene, good, and aseptic technique, great. All right, during the night shift, Jane's IV site has infiltrated. The nurse and the charge nurse attempt, and this happens all the time, the nurse and the charge nurse attempt to restart Jane's IV to no avail. The nurse calls the CCU charge nurse, calls the CRNAs. They are both tied up with multiple emergencies, and Jane is unable to have her IV restarted for many hours. The next morning at 4 a.m., Jane finally has her IV restarted, and the nurse restarts her heparin IV drip. Around noon, Jane calls out to her nurse complaining of increased anxiety and difficulty breathing. The nurse assistant takes Jane's vital signs and obtains the following reading. Blood pressure of 80/40 and a heart rate of 125. What condition can Jane be experiencing now? PE, pulmonary embolism. Good. So with this condition, what are some signs and symptoms that you may see? Shortness of breath. I'm sorry. Sometimes you can see coughing up blood. Yes.
Chest pain.
Difficulty breathing. Chest pain. Impending doom is a great one. What about her 2 vital signs that were taken? So increased heart rate, tachycardia, and hypotension. Absolutely. Okay. What about when you listen to her heart? What may you hear? You may hear her. Absolutely. And then while you're here at the heart, what is something else that you may see? You're kind of up in this area. What's something else you might see? JVD, jugular vein distension. Absolutely. She might also have an elevated temperature. She might have chills. Absolutely. What about her legs? Legs and arms. What might you see there? Poor perfusion or so. Go back to your little PowerPoint a little bit. There's one more thing there. That's more of a DVT. Peripheral edema, yes, we'll see that as well. So what type of diagnostic test will confirm that Jane has a PE? BQ scan is the best thing, yeah. Chest x-ray sometimes will not show up that well, but a BQ scan or that CT scan of the chest will show it, yeah. Also, you might see an elevated D-dimer, and with the ABG, you might see hypoxemia or that respiratory alkalosis as well. So how would you treat her condition? Notify the doctor. And when are you going to notify him? Immediately. Good. So what are some other interventions that you would be doing? Good. Put oxygen on her, exactly, and then start that heparin IV drip, or she's already started, but continue that heparin IV drip. Okay, Jane now has been in the hospital for 3 days. She is experiencing a temp up to 101 orally. She has chills, nausea, and vomiting, and she is experiencing suprapubic pain. What condition may Jane be experiencing? A UTI, yes. And what puts Jane at risk for this condition of a UTI? The catheter. And it wasn't just one, she actually had 2 catheters. Okay. And what are some other things too? Diabetes, yeah. The C-section she had. That could be possibly, but why did she have that second catheter put in? Urinary retention. Urinary retention sets you up for UTI as well. All right. So the nurse calls the physician to notify Jane of this new condition, or to notify Jane's new condition, excuse me. What can the nurse anticipate that the physician will order for her UTI? Urine sample, yeah. And for UA and urine culture and antibiotics. Good. And then also, she still has that catheter in. What might they discontinue? Exactly, because that's probably the source of that UTI. So getting that invasive catheter out. And, okay. So now, we're at the end. Jane is finally cleared up. She's all good now. After an additional few days of being in the hospital, Jane's vital signs have stabilized. Her labs are stable. Her INR level is therapeutic on her Coumadin. She is voided without problems, and she's now ready for discharge. As Jane's nurse, you know that it is very imperative that she receives quality patient education to prevent any further complications or readmissions to the hospital. So we're going to go through each of those topics, and I want you guys to let me know what are some good discharge information that you want that the patient really needs to have. So for the thrombosis, what is the long-term medication she's going to be on for the DVT and PD? Coumadin. Now with Coumadin, what are some things you want to teach her about? Signs and symptoms of bleeding. Get the labs checked. Diet low in vitamin K. Watch for those signs of bleeding. Absolutely. And so, absolutely, importance of follow-up labs and the medication regimen. Good. So if she has any signs and symptoms of any worsening issues, what do you need to tell her? Call the doctor. And if she has any shortness of breath, call 911. Good, good. Now, with her having a PE, how long would you think that she would need to be on Coumadin? 3 months, yes. For a PE is traditionally around 3 months. Good. Now, for her C-section wound infection, what do you want to teach her at home? Hand hygiene, aseptic technique with dressing changes. Keep it covered.
Importance of taking all the antibiotics.
Importance of taking the antibiotics, yes. What type of diet would you want her to?
High protein and vitamin C.
And vitamin C, good, high protein and vitamin C. And what can she do? Well, she didn't have a perineal tear, so we're good. So for urinary retention, that's the only thing she didn't have, that's right. So urinary retention, what are some things you can teach her at her home to help her get urinary retention? Peppermint oil, get up and ambulate, absolutely. Good job.
And don't wait, go.
Yeah, don't hold your urine in, go, that's great. Right. And then what are some, for the UTI, that you can teach her as well for patient education? Wipe it front to back. Your antibiotic as directed, yes. What about, what can she drink? What would you want to drink? Cranberry juice. And why is that? Acidic, good. And then also increase